So as I said, you're all very welcome to this evening's session. My name's Michael, so I'm one of the dietitians working here at NEDRC. I work in a part-time capacity with sort of the outpatient individuals, and some of you might know me from sort of the past few weeks or months of your loved ones, I suppose, being here. And NEDRC, and you're all very welcome. So I said we're going to cover a topic that I suppose needs a bit more recognition, something that's a little bit more kind of relevant, particularly ahead of this week, it being Eating Disorder Awareness Week. So we're going to cover the topic related to ARFID, which is essentially Avoidant Restrictive Food Intake Disorder, as part of our series of webinars that NEDRC is offering this week as part of Eating Disorder Awareness Week. Great, I'm just going to let other individuals in there as well. I suppose what we're going to cover this evening on a few different sort of topics. So we're going to essentially address what ARFID is and I suppose what it's not, distinguish it from other aspects of, I suppose, fussy eating. What are the different types of ARFID, the different forms? We know that there is at least 3. What are some of the health implications and nutritional consequences related to individuals that are suffering with ARFID? What are some of those key nutritional considerations that we see in the clinic, particularly in the context of ARFID? What is, I suppose, the nutritional goal or treatment from a dietetic perspective? And how, I suppose, from our perspective with family and friends can help support our loved ones with ARFID? And I suppose I've just provided some key resources for you to suppose take home with yourself and I suppose click on those links in your own time. I suppose in keeping with the theme this year of Eating Disorder Awareness Week, which was essentially entitled All Stories Matter. So I felt it was, I suppose, worth briefly sharing what some of those perspectives and real life experiences of individuals suffering with ARFID as well as their family members. And I suppose it's a kind of in keeping with, I suppose, the theme. So I suppose just quoting some individuals, particularly from the perspective of an ARFID individual, saying that, I always feel like a pain, whether this is to my family for having to prepare certain meals, for my friends having to avoid certain restaurants when I dine with them and everyone around me, when I start hyperventilating because of something unsafe contaminated in my meal. From, I suppose, a parent perspective of a child with ARFID, they may, I suppose, experience a lot of people don't understand and just think she's a fussy eater, and I suppose doing it for attention. What about, I suppose, the loved ones like siblings with a patient with ARFID? With a sibling, I felt quite powerless, but I learned a lot about what worked and what didn't, and came to appreciate how my brother felt rather than concentrating on what he did and didn't eat. So I suppose these are kind of real life quotes of individuals either suffering with ARFID or the family members that have to experience living or being with the individual with ARFID. And it can be very daunting. It can be a very stressful time. And I suppose having that realization that it's a very visceral thing, and we do need to pay attention not only to the ARFID sufferer, but also for the family members. So I suppose we'll start off by understanding what ARFID actually is. So we know it was a newly recognized and diagnosed eating disorder as part of the Diagnostic Manual of Statistics, and it was recognized back in 2013. So we know essentially it's a disturbance in one's eating or eating pattern that can result in one of the following. So we know it's a significant weight loss or not achieving expected weight, particularly in young children and adolescents, or the growth trajectory, both in terms of height and weight. We know there can be significant nutritional deficiencies and consequences to individuals suffering with ARFID, for example, protein deficiencies, but more geared towards vitamin mineral deficiencies that we actually see in the clinic itself. We know that there's a real dependence on additional nutritional supplements other than from food, things like what we call oral nutritional supplements, in order to achieve all of their nutritional requirements as well. So these are the main kind of facets of, I suppose, the diagnosis of ARFID. I suppose distinguishing it from what ARFID isn't in terms of the context of ARFID versus fussy eating. We know ARFID is, I suppose, a persistent food avoidance, which can lead to very severe medical complications if untreated. An example of this would be malnutrition, which I'm going to cover in the next few slides, aside from other clinical and medical conditions. We know it can be linked to a persistent anxiety related to eating and eating episodes, and it does require clinical intervention from a cohort and group of medical professionals. When in contrast to this, in terms of fussy eating, we know it can be common in children, but it's very much outgrown. We know there's preferences without nutritional deficiencies that can arise. And I suppose there's no, and most importantly, not necessarily any severe functional impairment. So distinguishing that from ARFID. So how is ARFID recognized and diagnosed? Well, we know it's a form of restricting the amount and or variety of foods, but it's not explained by concerns related to weight or body shape, such as in anorexia nervosa or bulimia nervosa. We know it's not related to a lack of food or cultural practices as well. So individuals living in different parts of the world where there's perhaps not access to culturally appropriate foods, we know that's something that's distinguished from an ARFID diagnosis. And it's distinguished from any other type of mental health disorders as well. In line with this, we know it's leading to severe consequences such as significant weight loss or failure to thrive, or what we call faltering growth, both in adolescents and teenagers in terms of their height as well as their weight. We know there's a consequence of certain nutritional deficiencies as well that we'll go on to discuss in later slides. We know there's also a dependence of those nutritional supplements that we had mentioned before. This leads to ARFID as well as a diagnosis. And essentially there's 3 different types that I'll cover in the next slides. But how common is ARFID? How often do we see it in the clinic or even in the population? When we distinguish from it from the different eating disorders, we know that ARFID is essentially responsible and is part of around 5% of all types of eating disorders. Now, it is more newly recognized, so it can be higher. It's almost like an iceberg effect where we're only seeing the tip in terms of its manifestation, given the fact that it's newer. But it does represent upwards to around 2% of the population, but it can be as low as 0.3 to 2%. This is what I suppose is in the current literature. We know the age of onset, it's usually in childhood, but it can be present all the way up to adulthood as well, if it's not diagnosed early on. And we know it's more common in males. Unfortunately, it is on the rise. We can see based on statistics, both in the UK and Ireland, that there's an increased prevalence and also incidence, means there's an increased number of ARFID diagnoses in the last 2 years as well. So it is something that we do need to pay attention of, given the clinical manifestation, the consequences in terms of our health with individuals suffering with ARFID. So what are the different types of ARFID? We know that essentially there is 3 different forms. One is essentially an apparent lack of interest in eating or even in food. We know that these individuals have very low hunger cues or hunger signals. There's very poor interoception, meaning that there's this low sensation or feeling that signals our body how we feel. And we know that these individuals can be very easily distracted. There seems to be a co-occurrence with other neurological conditions like ADHD as well as autism. You might hear an individual with this type of ARFID saying that they just never feel hungry, never have an appetite. So it's very difficult for them to, I suppose, eat and get enough of their nutritional requirements as a consequence. The other form of ARFID is essentially the avoidance based on any aspects of sensory issues. So issues or sensory issues related to the taste of the food, the smell, perhaps the texture, even the appearance and the temperature. You'll hear a lot of individuals with this type of ARFID having sort of beige foods, not very colorful foods. They can be extreme selective eating, or even they might have what we call neophobia of foods, so fear of trying new foods and need to have the same types of foods. There's a greater amount of what we call the fungiform papillae, which is essential structures on the tongue that, I suppose, hold the taste buds together. And that means that their taste perceptions are actually quite different from the general population. They can be described as what we call super tasters, where they might even taste very strong and bitter flavors more than what you and I might have. So that sort of leads them to avoid certain foods, particularly things like fruits and vegetables that are very kind of strong and tasting. So you might hear individuals with this type of ARFID saying that they don't actually eat vegetables, they're just extremely bitter. They might even gag on them as well as a consequence. The other or third form of ARFID is essentially concerns around the negative consequences of eating. This can be as a consequence of fear of choking. They may have had a traumatic experience in the past where they've choked on a certain type of food, which is leading to food avoidance. They might even have experiences of vomiting with food or even discomfort when eating. They might have also a type of functional dysphagia, which is a perceived difficulty in actually swallowing the food. And again, as I said, it can occur due to a really traumatic event in the past that they've had. So you might hear individuals saying that they just know that they're going to be sick if they even try and attempt to eat a food. It might be even so strong and severe as not having the food in the actual vicinity or in the place or even in the kitchen, but they just have fear of what might happen to them if they were even to see the food, let alone even eat it. So it can be that level of anxiety as well. So what are some of the causes of ARFID? We know it's a very complex condition, so it's not fully understood, also given the fact that it's quite a newly recognized eating disorder. We know that there's certain links to, I suppose, the environment. We know certain traumatic events can create the ARFID phenotype. So we know negative experiences related to, I suppose, food poisoning, as I said before, choking, vomiting, or even a bereavement due to a traumatic event in the past. If there's been a death in the family or friends, that can lead to negative experiences around food. We know that those that have a sort of obsessive compulsive disorder or disturbances in emotional or mental well-being have an increased predisposition to an ARFID diagnosis as well, leading to them avoiding certain foods and even food groups. We do know very clear that there's a link between ARFID and autism. So those that experience autism are more likely to have ARFID as well as vice versa. But we do know that not all autism patients have ARFID and vice versa. But we know that there's some of around 70% of those with autism can have, I suppose, a co-occurring diagnosis with ARFID, but these rates might even be higher than that with more research coming into play. We do know there's a genetic component or predisposition in ARFID. There's been some studies there done recently in Sweden where they've linked almost up to 79% of the risk of developing ARFID could actually be attributed by one's genetics or heritability from older generations within the family. So it is incredibly complex, and it's not just one facet, but I suppose multifaceted. And it's something that we do need to take into consideration in terms of treatment approaches that we provide for individuals with ARFID. What about comparing ARFID with other types of eating disorder behaviors? And I've kind of broken it down, comparing it to more prevalent eating disorders like anorexia and bulimia nervosa. Well, there's a difference in the time of onset. We know that ARFID, I suppose, occurs more chronic and long-term, where we know with anorexia it can be a little bit more acute. We know with growth and development, this is quite a key feature of ARFID, that individuals with ARFID can either be overweight or underweight, affecting their health. Could also be as a consequence of stunted growth can be an issue, but we know with anorexia, it's most likely diagnosed as an underweight, although when we compare it to other forms of anorexia, like atypical anorexia, those may experience weight loss, but might be at a healthy BMI. In terms of the variety of the diet, we know individuals with ARFID can be extremely selective. They can almost have less than 10 food groups that they feel safe to eat, almost extreme less than 5. We know this can occur in anorexia for different reasons, but usually the diet is quite varied, and it's more to do with their fear of being exposed to certain foods based on the consequence of them thinking that they're going to perhaps gain weight. We know in ARFID individuals, there can be certain risks of vitamin toxicity based on their reliance on certain supplements, things like vitamin A, iron, calcium. So we do need to be mindful when we do prescribe supplements for individuals with ARFID that they're not exceeding their daily amounts of these types of vitamins. We know in anorexia and bulimia that toxicity with those types of supplements are most unlikely. We can see that there's differences in food brand preferences. So you might hear from an individual ARFID that they're very specific and often have very similar brands of foods, that they don't kind of shy away from different types of brands because of the taste preferences being very distinct. But we know with anorexia and bulimia, that's not really the case. There's no specificity in brands unless there is some sort of anxiety around types of foods. When it leads to some certain functional aspects like constipation, we know that that's very likely in ARFID. We see a lot of constipation in ARFID, and usually this is likely due to the reliance of quite highly processed foods with low intakes of fruit and vegetables that contain fiber, which essentially helps with digestive health. We know that with an anorexia, this can be, I suppose, acute, but in the long term, when we do increase the amounts of foods and the variety of foods, that the likelihood of that constipation does subside eventually. So what are some of the health and nutritional issues in ARFID? You might come across either in social media or see news reports of individuals with, I suppose, fussy eating that might be linked to ARFID having certain physical and clinical consequences. We see reports of individuals even going blind as a consequence of restrictive eating or certain food groups. So we see this in the news, but what is the actual evidence? What does that actually look like? Well, we know from actually recent research, there's been a really excellent study, scientific study coming out of the University of Karolinska just last week in Sweden, where individuals who are researchers in the institute actually studied people with ARFID, both young and old, and actually came to certain conclusions that there are certain medical and clinical issues that individuals with ARFID face. And I've kind of broken down it into four. Four main issues are related to cardiovascular health or heart health, bone, hormonal health, as well as consequences of nutritional deficiencies. However, this is very much linked to what we call malnutrition and ARFID as a consequence. So what do we mean by malnutrition? Essentially, it's a state that refers to an imbalance in a person's intake or their energy requirements and nutrients over time. We know that can be as a consequence and leads to what we call undernutrition. These are individuals who are usually underweight in the likelihood of anorexia, nervosa, bulimia, but also ARFID. There's also the other spectrum of malnutrition that is, I suppose, less talked about and less understood, but it can be linked to what we call overnutrition. This is in the context of individuals who are overweight or obese, things like binge eating disorder, but ARFID is also can be prevalent in this demographic as well. However, this leads, I suppose, when it comes to undernutrition, we have deficiencies in what we call micronutrients like vitamins and your minerals. We can have loss of our own fat stores or muscle wasting that we see in individuals who are underweight and suffering with ARFID. We can also see an inadequate source of micronutrients or micronutrient deficiencies like your vitamins and minerals, particularly with individuals who are overweight and also suffering with ARFID. There's also certain chronic lifestyle-related conditions like heart disease and diabetes having an increased risk, as well as cancers, when individuals with ARFID are at an exceedingly weight, such as overweight and obese. But I suppose the take-home message is that ARFID can cover both aspects or spectrums of malnutrition, either being undernutrition and underweight, as well as overnutrition and being overweight as well, can affect both aspects of the spectrum of malnutrition. So what are those nutritional and physical consequences of individuals that can suffer with ARFID as well? And this is, I suppose, in the context of those who are underweight. We know that there can be a loss of cardiac muscle or heart muscle that's caused by malnutrition. The body's extremely adaptive. So if an individual with ARFID is not meeting their nutritional requirements, meaning their protein requirements, their energy or calorie requirements, the body will, I suppose, compensate and utilize protein and heart muscle as a consequence in order to meet those nutritional requirements and provide energy. We know that it can be linked to what we call a low heart rate or bradycardia, which can lead to abnormal heart rhythms and heart failure if not actually treated. There can be signs of low blood pressure, where there's electrolyte imbalance or your minerals imbalance by not actually optimizing your nutritional intake as well. What about bone health? We know there's certain consequences to individuals who are suffering with ARFID, both who are underweight as well as overweight if they're not meeting certain nutritional requirements, particularly calcium and vitamin D, which I'll go into in the next slides. These can lead to certain conditions that are related to bone health, things like osteomalacia, which is described as the softening of bones as a consequence of low vitamin D intake or vitamin D deficiency as well. Can also be as a consequence of osteopenia, meaning there's a loss of bone mineral density, which can also lead later in life to a condition known as osteoporosis, which I'm sure many of you have heard of. We know that's a loss of bone mass over time, and we know that that can be irreversible. So as a treatment plan, we do need to be mindful, particularly with adolescents and teenagers who are developing their bones at a rapid rate between those ages up to 18. We do need to be very mindful of, I suppose, the intake of certain nutrients that are linked to bone health, things like calcium and vitamin D, especially because we know that once bone is formed, we know there can't be any increase of bone formation, and we know that the osteoporosis is very much an irreversible condition. So we do need to be very mindful of that. What about the hormonal impact for individuals who are suffering with ARFID, particularly those who are underweight? We know that in females, that can lead to delayed puberty. There's a reduction of a key hormone, which is estrogen, which can lead to the loss of period or amenorrhea. We know that the rates are around 10% in ARFID is what the scientific literature actually says. And therefore, there can be a increased risk of fertility, I suppose, in individuals who are experiencing amenorrhea for around 2 to 3 years. We do need to be very mindful that when I see a patient that we are kind of focusing if they are amenorrheic or if they have a lost period, that we do need to make sure that is restored with proper nutrition as well, meeting their requirements for both energy and protein. There can also be a risk of osteoporosis given the role that estrogen can play in the formation of bone and bone health as well. There's very much a link between those two. What about in males? We know there can be erectile issues. There's a decrease in sperm count. There can be low testosterone, which is a consequence of the hypogonadism, which is the shrinkage in their testes, leading to low testosterone levels. There can also be, I suppose, hormonal issues that are experiencing by both genders, leading to low thyroid levels, which can reduce, I suppose, metabolism, which is very much responsible. The thyroid gland is responsible for this, which can lead to, I suppose, tiredness and feeling cold all the time as well. There can also be high cortisol levels that are flowing in the bloodstream, which can, I suppose, if not treated, lead to high blood sugars and even blood pressure issues as well, such as hypertension. So we do need to be mindful of this when we're, I suppose, assessing and reviewing the patient. What about those nutritional deficiencies? We know that around 67, so more than 2/3, or just under, 2/3 of individuals with ARFID don't actually meet their recommended daily allowance or their vitamin and mineral requirements. It's quite significant. That study that I alluded to in the Karolinska Institute in Sweden that just came out last week have actually grouped together what are the main nutritional deficiencies in terms of your micronutrients that are very prevalent in individuals with ARFID. We know vitamin C deficiencies are very, very common, and this is more in the context of the highest to the lowest. So vitamin C seems to be the most deficient vitamin that is experienced by individuals with ARFID. We know that it has a role to play in the immune system, immune function. Certain foods that contain vitamin C, as we know, citrus fruits, as well as certain veggies like peppers. And we know historically a vitamin C deficiency has led to conditions such as scurvy, which is essentially a decreased red blood cell count, can lead to certain gum diseases, changes in hair, and even bleeding from the skin. I know this is a historical context, but we do see this in the clinic as well. So we do need to be mindful of those signs and those symptoms. We know that vitamin A deficiency can co-occur in individuals with ARFID. We know that can lead to, I suppose, vision loss. We know vitamin A is very much responsible for vision, growth, and development, particularly in young adolescents and teenagers. I suppose foods that contain vitamin C would be, I suppose, your kind of orange-colored veggies, things like sweet potatoes, carrots. They're also found in meats, citrus fruits, as well as cheese, and certain consequences that can lead to a vitamin A deficiency is a condition called xerophthalmia, which is a condition where, there's a reduced amount of tear ducts, which can lead to very dry eyes, and if non-treated, lead to, I suppose, night blindness, which is known as nyctalopia. So we do need to be very mindful of that. There can be deficiencies in what we call our B vitamins, things like B12 and vitamin B9 or folate. We know they're really responsible for metabolic health or metabolism. It helps convert food into energy, very much responsible for the formation of red blood cells and nerve function. We usually get these from foods such as red meats, and also fortified foods such as cereals and milks as well. But we know certain consequences of these deficiencies can lead to anemia, so low red blood cell count, as well as certain oral conditions like glossitis or neurological conditions as well if left untreated. We know vitamin D deficiencies are very much prevalent, not only in ARFID, but also in the Irish population, but very much in ARFID especially. We know that's very much linked to our immune system. It also helps with bone health. It's essentially the key that allows calcium to come into the bloodstream and into the bones to help with bone formation. We know that vitamin D is very much prevalent in fortified foods, things like milks and cereals, as well as supplements, also found in certain portions of fish like salmon, tuna, trout. We know certain consequences of vitamin D deficiencies can lead to a condition known as rickets. I'm sure many of you have heard of this, which is essentially the softening or weakness of the bones, which can result in osteoporosis. And you see it's sort of the bow-shaped legs of individuals, which, at one time would have been a historical condition. We know there's certain rates of rickets increasing, particularly in Ireland. So again, it's something that we do need to be mindful of. There can also be deficiencies, I suppose, in iron as well, something that's very prevalent in individuals with ARFID, very much responsible for growth and development. And we know iron is very much present in, I suppose, fortified foods, things like cereals. It's also prevalent in meats, as well as other vegetarian sources like beans and pulses like lentils or chickpeas. But we know that low iron can lead to, I suppose, anemias, known as iron deficiency anemia, which can, I suppose, have some impact on our immune system, as well as our cardiovascular risk, such as heart failure. So there are certain conditions that we do need to be mindful in which we can help the individuals reduce their risk of those types of deficiencies, and thus those types of health conditions that are a consequence of the deficiencies itself. So what about the dietetic management? As a dietitian, what is kind of my role in helping individuals with ARFID as part of their treatment goal? Well, we know the main treatment goal, as I suppose, depending on the individual and where they are, is achieve or maintain a healthy weight consistently. We also want to make sure that we correct any of those nutritional deficiencies that we might see that come up on a blood test, your vitamins, minerals, even protein as well. I have some individuals that essentially do have a very low protein diet because of fear of certain consequences of choking, or they might just have very adverse sensory perceptions of different types of protein-based foods like meats, or even vegetarian sources like beans as well. We want to make sure that they're eating foods from each of the 5 basic food groups, things like your fruits and vegetables, your protein, your dairy, and your grains, as well as your fats. And I suppose from a holistic approach, we want to make sure that they're actually becoming more comfortable, feeling more comfortable in eating in a social situation. You hear a lot of individuals with ARFID are very much avoidant not only of the food, but they're very much avoidant of social settings in which food is prevalent, and they may have, I suppose, a lot of fear in eating in front of individuals based on certain expectations or even consequences to the food itself. It's in contrast of what treatment isn't when it comes to ARFID. It's not about trying to change their behavior or their personalities towards food, because this is very much individualized, and food is very much based on food preferences as well. It's not about making the individual with ARFID eating very unusual foods that they may not have, and it's not about force feeding as well. So what are the different stages, I suppose, from a dietetic approach of ARFID in terms of treatment goals? Well, we kind of broke it down into 3 different stages as well. The first stage, I suppose, when I see a patient is through, I suppose, educating them on the nutritional needs of the basic food groups. So informing them around what ARFID is, the rationale for why they need certain nutrients, why they need certain foods to help with maintain their health, maintain their weight. There may be a necessity to increase the volume or the amount of their preferred foods from the initial stages, particularly if they're underweight, and I suppose for the variety for all of the individuals. We can sort of move on to the next stages where we incorporate certain food exposure techniques to help them gain confidence in trying to have certain foods. This can look at what we call desensitization of foods, so trying novel foods or foods that they may have stopped having in the past for many reasons and trying to re-expose them or to try new sort of foods. We do try and provide anxiety support, and I know a lot of the psychotherapists and psychologists would help support individuals who are experiencing heightened levels of anxiety around trying new foods as well. We do and try and address what we call the interoceptive exposures, so recognizing, I suppose, hunger and fullness cues, those signals that I suppose can be very much absent in individuals with ARFID as well. And then we look to see on the next stage, stage 3, any relapse prevention plans that can help mitigate the relapse. So review their, I suppose, their treatment goals, their initial treatment plan, and identifying future treatment goals at home in order for them to gain confidence to be able to help themselves when they're sort of out of treatment as well. A little bit about weight restoration, ARFID, because we know, especially the patients that I see, a lot of them would be underweight. So we do need to help them understand the rationale why they need to gain weight and how they can do it. We know that being out of a low weight or even a low BMI can be quite dangerous to health. There's certain consequences to that, anywhere ranging from, I suppose, low mood or energy. We know that individuals with ARFID, but not only ARFID, with restrictive eating, particularly in anorexia nervosa, we can have, I suppose, low brain mass or lower brain shrinkage. There's been studies where they've compared individuals with ARFID and anorexia and restrictive eating. They've looked at MRIs of brain scans and PET scans of individuals who have been restricting, and they can see very much different profiles in the grey and brown matter, which can be linked to neurological health. We know this can be reversed with adequate nutrition and, I suppose, weight gain to help restore brain function. We know stunted growth, both in terms of height and weight, can be as a consequence of a low weight. We know this also can be as a consequence of low bone density if those that are suffering with a low weight, simply if there's a loss of period, and we know that that's linked to low hormonal health, which is also very much linked to bone health as well. As I said, there can be a loss of period if one is underweight, or in males, a low testosterone level. And we know, unfortunately, there can be an increase of premature death as a consequence of low weight being persistent for a long period of time, particularly in adolescents and young children. So what are the strategies that we can use and the tools in the toolbox for helping individuals gain weight, particularly in ARFID? So I suppose it's eating more of their preferred foods, particularly from the initial stages when there is a limited variety of foods for many reasons. If there's some anxiety around food or fear of consequences of trying new foods. So trying to increase their exposure of their preferred foods to help kind of mitigate anxiety in the initial stages. And it can look like anything. It doesn't necessarily have to be certain types of food and food groups. It really is based on their preferences and just trying to optimize and increasing the volume of foods. We do want to make sure from the get-go that they're regularly eating throughout the day. So having their 3 meals and at least 3 snacks every 2 to 3 hours. For many reasons, this helps regulate, I suppose, their appetite. It can help increase their hunger hormones when we eat regularly, and we'll discuss this in later slides. It also helps regulate their blood sugars and provide energy. Pairing snacks is also a thing that we really help them to do to increase their overall calorie amounts. So pairing things like having sort of liquid-based like milks or smoothies with toast, with nut butters, can help increase, I suppose, the snack intake as well. We do try and increase their overall calorie intake by at least 500 calories a day, which does help in aid in weight restoration. But again, this is on a very individual basis, and that would be, I suppose, as a minimum. We do have to see the patient in front of us, and we do very distinct calculations that help us assess how much weight they need to gain and at what trajectory. Sometimes an individual who is very much underweight and suffering with ARFID may have to stop or reduce their level of physical activity for a short time in order to help restore weight. Because we know that increasing your energy expenditure can reduce your overall calorie intake and reduce your weight. So we do need to be mindful of that as a temporary fix. And we know that family supervision is also a very big key to help with supporting individuals with ARFID during the meal times as well, particularly with adolescents and young kids. And some snack ideas that we usually provide here that help with increasing the overall calorie intake, especially if there is kind of a limited appetite. Things that I found, I suppose, to work is, liquid-based snacks that are higher in energy, like milkshakes, more nutrient-dense foods like pizzas, or even hot chocolate with biscuits, flavored milks as well, with, I suppose, bread, butter, or peanut butter. An example could be certain snacks like chocolates or even waffles or flavored milk as well, as a minimum of those 500 calories. What about a little bit about food exposure? We move on to those that second stage when we've kind of optimized their intake and prevented any further weight loss. Well, we did discuss about this food exposure, and I've developed some documents that can really help with that. But what we do is we want to create what we call the food hierarchy list. So we try to assess exactly where the patient is at in terms of what kind of foods they're willing to try, what foods they're most likely to have currently. So I develop what we call a green light system, or traffic light system rather, where I try and document what foods they're most comfortable with and what foods they're most likely to have at a time. And we work our way down to foods that I suppose they would never think they would have. And then we kind of develop what we call a food hierarchy, where they start with foods that they're actually willing to try on a scale of anxiety level. And then we sort of keep track of that from a food group builder. So we go through all the different food groups and we see what kind of foods they're willing to try, and and keeping track of how many times they've tried that, because repeat exposure, I suppose, is key as well in helping them to gain confidence with trying foods again. So what are the different kind of steps of, I suppose, learning about new foods? So we know we kind of break it down into those 5 steps in no particular order, but really it is how we can visually, I suppose, see the food in terms of that new food exposure, how the food looks as well. Again, there can be a lot of anxiety around even kind of looking at the food. So it could even be the fact that the food would be in the same vicinity. I have had some patients where they just can't even have the food in the same room or even in the same fridge. So even just getting exposure to the food being within the same room can be quite significant. But we look to see, ask some questions on how, I suppose, the food looks, how does it feel, smell, and then if they're willing to try, even taste using different parts of their tongue based on the tongue preferences. There can be areas that are more bitter, more sweet. So we get them to explore that. And what the texture is like, and if they're comfortable to try and chew the food, and then obviously swallow. And again, it does take up to 10 times to actually try food in order to assess whether they actually like or dislike a food. And it's not about trying or thinking about going to like every food. It's more just about the trying, and they're not going to, I suppose, like every single food. What about the different strategies that we can use to help individuals with ARFID incorporate either previously tried foods that they've stopped eating, or even kind of new foods as well? Well, there's different types of ones, and there's 5 strategies that sort of I use within the clinic. One is, I suppose, is increasing the foods gradually. We essentially call it fading in. So we start with a very preferred food, a higher proportion of this, and we sort of gradually reduce those ratios. So, for example, it could be something like they're very comfortable with trying roast potatoes, so we try and reduce maybe a quarter of that on the plate, or even half of that on the plate, and we sort of mix it in with a different form of potato, like mashed potato. So we reduce those ratios and fade in the more challenging food, so that they're increasing that amount, and towards the end they've actually faded into a different transitionary food. Other strategies that we can use in the clinic is adding preferred condiments, so their preferred sauces as well. That can really something that they're very much used to in trying taste, which can help them train their taste buds into accepting more other kind of foods or stronger flavors that they're very much used to. Things like ketchup, mayonnaise, or brown sauce, or things like cheese that they can add to certain veggies like broccoli, that they're very much used to that flavor profile. And then bit by bit in stages, helping reduce the reliance on the condiment and increasing the amount of the new food's flavor profile. Other strategies that we can use that can be quite successful is what we call food chaining. So it's really starting with a preferred food and sort of chaining it into a transitionary phase. So for an example, if they want to try a certain vegetable like a green bean, could be starting with something like crisps or veggie straws and then transitioning it to a different form of a crisp, trying a dried veggie straw, going to sort of frozen green beans or even peas, and then transitioning it across into kind of steamed or cooked green beans. And there's hundreds and hundreds of different types of food chaining techniques that we can use based on a certain food. It could be something like where they're very concerned of having things like fish, but they're very okay with chicken. You could even start with a breaded kind of chicken and then transitioning it across to breaded fish as well on a different chain. Sometimes changing the cooking methods can also be quite successful, whether it be cooked in a certain way, like steamed versus raw versus baked, or even fried. Trying to change the sort of the texture profile of the food can actually help in gaining confidence in trying it once they're very accustomed or climatized to the taste. And then based on, I suppose, the quantity of food and the different areas or preferences, even cutting up the food into smaller segments can help them sort of adjust. It could be based on kind of fruits. I know individuals who like the taste of sort of apple or apple juice, cutting it into small kind of pieces can help them gain confidence in trying, the bigger portion, or even trying a pizza for the first time. Many of them would have cut it up into different forms, like the crust versus the inside base. So you sort of get a different kind of profile, and it's not so daunting or overstimulating for the individual. But these are just some of the strategies that we can, I suppose, use in the clinic to help individuals gain confidence in attempting different types of food exposures. What about, I suppose, tracking progress? And it's something that we sort of developed here, where we also help them to understand where they've come from, because they want to gain confidence and realize how far they've come step by step, because it can be sometimes very challenging and a slow progress. So we've developed a food exposure work where I help them to keep track of the food, but I also want them, particularly in the clinic when we are doing some food exposure work, that they kind of understand the rationale of why they need to have those certain foods. So they kind of go through the nutritional aspect and nutritional knowledge, things like understanding what the food belongs to which food group, what's the key nutrient, and what role does it play in our health. Then I proceed, once they do a bit of food exposure work, is to suppose score both the taste and the texture out of a scale of 0 to 10, so that they sort of understand kind of where they are and how they can compare it to other foods. Usually as a kind of arbitrary reference, I always say anyone who sort of scores over a 5, that they're, I suppose, could be willing to try it again during the week. So anything that they sort of add to this list and they know that they can maybe try again, it's something for them to practice at home. In parallel, we also want to make sure that they keep, I suppose, a food diary. This is sometimes very important for individuals, particularly who are underweight, so that we keep track exactly of what they're, I suppose, having on a daily basis, and things that we can maybe help work towards goals and help either increasing rate or increasing the variety of foods. And sometimes writing out the times at which they eat and the different meals and snacks, they can kind of see certain patterns that can help them improve their overall quality of the diet as well. I suppose we also have to give some education around the different food groups as well, and I suppose balancing that on the plate. So introducing, I suppose, the food pyramid, understanding portion sizes and the different food groups and the rationale behind each food group and the nutrients that are very important for their health, and what this actually practically looks like in terms of portion sizes on the plate as well. So what a little bit about sort of interoception. I mentioned this before, and what this is in feeding and ARFID. So we know with interoception, and I know the occupational therapist will have a lot to say on this and a lot more detailed compared to what I'm sort of presenting, but in essence, it really is a sensation or feeling that kind of signals the body how an individual feels. And those with ARFID, we know that these sensations can be quite challenging, difficult to process or recognize within the different forms of ARFID. So we know that in individuals who have a lack of interest in foods, there's sort of minimal interoceptive cues. And we know that individuals that suffer from sort of the negative consequences, we know there can be heightened sensitivity, which can also have a knock-on effect of the interoceptive cues for individuals. Things like the thoughts of the food, is there's anxiety towards that, the temperature, the texture, the smell, and the color. And again, these can disrupt all the hunger cues, I suppose. And when we're not, I suppose, hungry, this can certainly challenge their requirements of eating and meeting their daily intake. So what about, I suppose, sensing those hunger cues and signals? Well, we know that there's certain hormones that are very much responsible for triggering hunger and fullness. One of which is very much prominent, particularly when it comes to the context of ARFID, is ghrelin. We know this is what we call the hunger hormone. It's very much responsible for making us, I suppose, feel hungry. It's produced, I suppose, in the stomach, travels to the brain, and it triggers the brain to have a response of feeling hunger. And we know that ghrelin levels can become very much low in ARFID when there's a delay in eating. And this is why, from the very beginning, we have to I suppose, recommend the individual with ARFID eat as regularly as possible, every 2 to 3 hours, to help stimulate appetite as a consequence to trying to get ghrelin levels at a peak. The issue is with ARFID, and we know from some of the scientific studies, that ghrelin itself, the hunger hormone, appears to be very much low in individuals with ARFID, as well as with anorexia, but even more so low in ARFID compared to the general population. So we already have a very low amount of ghrelin that's circulating in the system with individuals with ARFID. So it's very much difficult to try and get that hunger signal to be heightened as well. But one way in which we do try is to help maintain regular eating pattern, so eating every 2 to 3 hours, to help stimulate ghrelin as much as possible. In contrast to this, we also have a hormone called CCK, which is essentially our fullness hormone. And these, unfortunately, levels appear to be higher in ARFID individuals compared to the general population. So you suppose have a double whammy or a double effect, where the fullness hormones are also at the heightened. So, we do have, quite challenging in help to stimulate appetite from the get-go based on these hormonal abnormalities that we see in ARFID individuals. So one way which we sort of help individuals, I suppose, recognize their hunger cues or their hunger signals is using what we call the hunger scale. Some of you may have come across this before. We try and quantify hunger signals based on this hunger scale, with one being, kind of ravenously hungry, feeling almost dizziness. We sort of attach a sort of symptom with the scale as well, so that they really understand where they are. We do recommend individuals, when we're practicing these hunger cues and the hunger scale, is to aim to start eating at a scale of 3 to 4. And then finishing at a scale of 7 to 8 as well, so that they sort of start to understand the interoceptive signals of the hunger scale. Sometimes this can be really effective depending on the individual, so they start to recognize where they are in the scale and then eat accordingly to help stimulate appetite and to stimulate fullness signals as well. Some other interoceptive strategies that we can see in ARFID and some of the evidence points to, we know that can be really challenging with individuals with ARFID, and they may not have that interoceptive sensation, as I mentioned before. Things like the feeling of bloating or fullness or nausea. So in order to stimulate those sensations, we can help do some exposure exercises. So understanding what bloating or fullness looks like, sometimes pushing the belly out as far as possible, at least for 30 seconds, to help understand what that feeling of fullness is, or bloating rather. When it comes to fullness, gulping several glasses of water kind of rapidly for them to understand the difference between sort of that fullness cue as well. and sometimes experiencing nausea if they've kind of undereaten or overeating, spinning on a chair for around 30 seconds. Believe me, it does work. I've tried it myself. I suppose, what about supporting loved ones with ARFID when we sort of boil down to it? We know that we want to validate their experiences and I suppose as much as possible avoid pressure because we know there's a heightened level of anxiety that's attached to the condition as well. We know ARFID is not just about picky eating, as I've said before. It's really an eating disorder rooted in sensitivities to any kind of sensory overload, anxiety, trauma. Um, so what can we do to help? Well, really, it is very much acknowledging their struggles without dismissing, I suppose, their very visceral or real fears. So avoiding phrases like, things like just try it, you'll grow out of it. This can be quite triggering for them and can increase their anxiety. So instead of saying that, we can say, we understand that it's really hard for them and that we have to try and find a way to help make it easier for them as well. We also want to support their nutritional needs, again, without overwhelming them. So we know from that previous research, as well as in the clinic, that many individuals with ARFID do struggle to meet their nutritional requirements. That's part of the diagnosis. And that can lead to those deficiencies that we mentioned, things like iron, your vitamin D, or B12. So what can help and what we'll be seeing that can be quite successful is using what we call food fortification techniques. So increasing the overall nutrient density or calories, but not necessarily the volume of food, particularly if their appetite is still quite low. Things like creams that we can add to smoothies or even protein powders. We can offer kind of liquid nutrition, as I said, smoothies or milkshakes. We can fortify them with different components and even using things like oral nutritional supplements as well. And that is sometimes a requirement. I suppose what are the sort of take home or key messages that we kind of want to get out of this session? So we know, again, it's not about being just a picky eater. We know ARFID is a serious eating disorder that does require specialized intervention from a group of healthcare professionals, not just from a dietetic perspective. We know that there can be nutritional deficiencies as well as malnutrition. It's very much common in ARFID. It does require sort of individualized approach from a dietetics perspective in an intervention to restore, nutritional status, restore weight sometimes as well. We do try to use interoceptive training and that behavioral techniques, things like food exposure, CBT, along with the psychotherapist to help rebuild those hunger and fullness cues and reduce that food-related anxiety. It is very much a multidisciplinary approach. So I'm only one cog in the very specialized wheel of healthcare professionals that really help towards treatment with individuals with ARFID, like the psychiatrists, the psychologists, the psychotherapists, OTs, nurses, the likes. But we do know recovery is possible with the right support. And, over time, ARFID individuals do expand their diets and they can meet their nutritional needs. And it does help them improve their quality of life. So I've just provided some resources for anyone who's interested in reading up a little bit about the topic more. So I know that NEDRC, we do have some resources along this topic. If you've not come across Bodywise, I do encourage you to read some of their information leaflets when it comes to ARFID. There's some really great resources that they've done recently. And I suppose there is an equivalent of Bodywise within the UK called Beat. They have some really great resources on ARFID as well. And in the States, there's some really excellent webinars. If you haven't come across this website, I really encourage you to do so around sort of ARFID as well as other types of eating disorders. But it's a really great resource to avail of. So I'd just like to take this opportunity to thank you all for joining, and I hope you've, I suppose, got some extra information around the condition and some exposure that I suppose needs to be more given the rise in ARFID and the incidence and the fact that it's a more newly diagnosed eating disorder condition. And if any of you have any questions, I think we have a few minutes left. If you'd like to ask any questions, or you do have my email address as well. So please do feel free to email me at any time. I'd be more than happy to answer your questions.